Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to tell you about an interesting pain case, a knee pain case, left knee pain on a college football player. He was brought in by the athletic trainer. He's had chronic knee pain for a couple years. He can play through it, but it flares and, it'll get worse and better, worse and better. And they've done just about everything they could think of. They use shockwave. They do all the myofascial stuff, Graston, of course, stretching, massage guns, cryo. They have a lot of tools, and I think they know when something needs some basically electric stim acupuncture, and so they'll bring some of the tough cases in, and they're usually the superstars of the season that they need to be playing regularly. So I saw this guy for the first time. We worked on several things because it was his first visit, and he had more than one injury and problem. But I was surprised after treating his quads, TFL, glute min, glute med for like IT band, treated the quads, gracilis, that he still had left knee pain, and he could reproduce it just by bending his knee. Lying on his back on the table, he could bend his knee and tell me that it still hurt. So it kind of surprised me, but I immediately thought, okay, short rectus femoris, let's see what's going on here. And I asked his permission to palpate his upper thigh, and I asked him if he ever gets any sore tight bands in there, and he said, yeah, it always hurts there. And I palpated. I felt lots of ropey, tight, painful trigger points in his upper quad, in the rectus femoris. So we scheduled an appointment appropriately for him to be able to basically have a day of recovery, because I didn't know how sore I was going to make him by dry needling his upper quad. I didn't want him to have to do anything major the next day. So we scheduled that appointment, and I dry needled. I was very gentle. I dry needled his upper quad. I got several really good twitches out of it. And of course I did a lot of other stuff, maintenance stuff, but for the knee pain, that, I did do all the motor points for the quads again, everything, TFL, glute med, whatever. And I treated posterior chain, hamstrings, all of it, but the dry needling, he couldn't tell for sure if he knew his knee felt sore, still on bending, but not as painful. So I thought, okay, well, let's just see how it heals, because it's still tight. It's still got inflammation. And so I just saw him yesterday, a week later. He confirmed that he was sore that night, but he was better the next day. He said he got 2 days of practice with zero pain, and he was very happy about it, but the pain did come back. And so I said, okay, I think my diagnosis is correct. We just need more of the same treatment. And this time, yesterday, I was saying, that it's such an odd thing for you to have painful trigger points in your upper quad just as an overuse injury. This looks to me like it was some sort of trauma. He said, "Yeah, a guy I was playing, it was in a game, and a player landed flat on my leg. He was already on the ground, and a guy landed flat on the top of his leg. And ever since, he had knee pain. And I think they'd been blaming the injury for doing something to his knee, when in fact, the trauma was to the rectus femoris, which had shortened, contracted so much that it was affecting the movement of his knee and causing knee pain. So I I did a bit more. I knew that he healed really fast from the first treatment. So I said, if you're good with it, we're going to go for this and really try to get really good release today. And he was fine with it. And I was, of course, very gentle. I used a 30 gauge needle. When I insert the needle, I confirm with him that I'm in a spot that is not painful. I said, okay, I'm going to stay right here until it twitches, and I'll just stay there moving the needle in and out slowly until I start getting twitches, and then I might, get another needle and try another spot. And I got really good twitches and release, not just in the rectus femoris, but a lot of the vastus lateralis was affected. So we got great twitches and release, and I believe that I know that his trigger point pain reduced, and when he bent his knee, he could feel that it was still sore, but it was better. So I said, okay, let's wait and see. I'm pretty optimistic that we're going to get him out of pain. It may take us one or two more sessions like what we just did, but if he keeps coming back reporting better results, longer lasting results, then I know we're on the right track. And I just thought it was such an unusual knee pain case that I wanted to share it. I think it would only happen to someone like an athlete, because it was basically a trauma to the muscle that caused the knee pain, and it wasn't really an injury of the knee joint itself. And it's been going on for him for like 2 years. So I'm optimistic, and I'm excited that we're going to get rid of this 2 year issue. I know he has his sights on playing professional football. So this is something that will be really meaningful for him to get rid of. And I just thought it was a really interesting knee pain case. Trying to think if there's something else that I can tell you about it. I did do some trigger points on his other leg, because every once in a while he'll have some lateral knee pain, and he had some significant trigger points in his vastus lateralis on the right side. So I did do some dry needling there. Yeah. So if you run into such a case where the motor points are not working and they bend their knee and they can feel the patellar pain, knee pain, maybe check the upper quads and see if the rectus femoris and or vastus lateralis have painful taut bands that are very likely restricting the elasticity of the rectus femoris, thereby putting pressure on the patella and pulling on the patellar tendon. Because I really think that's what's going on. Like I said, I'm really pretty sure that that this will be corrected. I need to make a correction to something I said last week in the podcast about one of the guys who had tingling in the hand, and I was proposing that perhaps the lower trapezius, along with the downward rotators, the levator scapulae and the pec minor, were all contributing to a downward rotation of the scapula and decreasing the space in the thoracic outlet. I have to admit that I was just thinking out loud, and I was completely screwed up in saying it was a downward rotator. Lower trap is an upward rotator. The traps are upward rotators, like the serratus anterior. And I don't know. I guess I was thinking about the rhomboids and the lower trap being so similar in that area. But anyway, lower trapezius is an upward rotator. I know that very well, and I'm just like whatever senior moment. I don't know. However, I will say that I think the theory still stands. Levator scap, pec minor, and lower trapezius could definitely be still compressing the thoracic outlet via the clavicle, because the upper trap attaches right on the top of the clavicle. Shortening of the lower trapezius very likely could be putting downward pressure on the clavicle via that connection with the upper trap. Even though it's not a downward scapular rotator, I do believe that combined with the shortening of the levator scap and shortening of the pec minor, the lower trapezius is very likely doing what I said as far as like depressing the scapula, but not via the fiber orientation, but just mechanically pulling down on the upper trapezius where it attaches to the clavicle. So I wanted to correct it because it's not accurate to say that it was downward scapular movement. I probably should say it was increasing some depression of the scapula, just by having contracted shortening of the lower trapezius with those trigger points. So sorry about that. If I confused anybody or if I sounded completely stupid, I am human, and I'm and I don't script my podcast. I come up with an idea, I turn on the computer, and I just start talking to you. So sorry if I wasn't accurate there. I still think my theory is good. It's just not for the reasons I was saying. Anyway, and if you didn't listen, now go back and listen and see what I really said, and see what you think about why trigger points in the lower trapezius can get rid of tingling in the arm or hand. Okay, that's it for this week. I hope you have a great week, and I will talk to you soon. Thanks.